Welcome to today's webinar. My name is Russ Rowan, and I'm the Director of Marketing for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you, be able to answer any questions you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time. We will try to get them answered during the webinar. At the end of the webinar, you will receive an email with a feedback survey. Once you complete that survey, an email with your CE certificate will be sent to you. So be on the lookout for that survey because that's what we need you to fill out to get your CE certificate. It's my honor to introduce tonight's presenter. Dr. Yusuke Hamada is Health Sciences Associate Clinical Professor in the Periodontics Section at the UCLA School of Dentistry. He earned his D.D.S degree from Kyushu Dental University before completing his periodontal residency program at Indiana University School of Dentistry, receiving an M.S.D and certificate in periodontics. He served as a clinical assistant professor at Indiana for pre- and postgraduate levels while directing its advanced education of graduate periodontics. Dr. Hamada is a diplomate of the American Board of Periodontology. He's involved in didactic and clinical teaching in both pre-doctoral and graduate levels. He received AAP Awards for outstanding teaching and mentoring in periodontics in 2017 and AAP Foundation's Nevins Teaching and Clinical Research Fellowship in 2019. He enjoys teaching and conducting basic and clinical research focused on hard and soft tissue regenerative procedures. And with that, I want to turn it over to Dr. Hamada. Dr. Hamada, once again, we appreciate you taking the time out of your day to present to us tonight. We're looking forward to it. The floor is yours.
All right. Well, thank you so much, Ross and the team of Osteogenics for having me here. And thank you for attending this webinar. My name is Yusuke Hamada. I'm a program director at the UCLA School of Dentistry program. My topic today is soft tissue management for dental implants. But specifically, I want to talk about a little bit different behavior of soft tissue between natural teeth and implants. So let's look at this one. So as you see from left side picture to right side of the picture, raise the flap, expose the bone, tenting screw, bone grafting, DPTF membrane, get the primary closure, 6 months wait, you will see nice bone on the right side of the picture. So what I want to say is that implant dentistry has focused on ridge preservation and augmentation for a long time. Yes, we really need the bone to stabilize dental implant to get the integration. However, how about soft tissue management of dental implants? We have focused on this area more and more these days. So when you look at this type of situation for right side, number 30 implant on the right side picture, number 4 implants. What do you pay attention? How do you think about these implant site regards to soft tissue wise? But these are 2 implants area or 3 implant site. You can see it with frenum attachment, thin mucosa, non-keratin tissue. So what do you think about these areas, especially patient in your office? So this is one of our patients that we saw it. We see nice frigida graft were done all the way around. The all implants are nicely restored, and I don't see any bone loss. No, I don't see any, but less amount of bone loss and pretty stable condition all the way. Nice soft tissue condition. But when you look at this picture, upper left side anterior area, needless to say, implants are slightly outside the housing. Then you can see very thin phenotype, mucosa recession, and so on. So what do we know about mucosa thickness and the keratin tissue width? So let's look at the paper. The peri-implant phenotype. Implant with thin phenotype, which means tissue thickness is very thin, has higher prevalence of peri-implantitis compared to thick phenotype. And also, implant with inadequate keratin mucosa width had a statistically higher prevalence of peri-implantitis. So we kind of know that. But the biggest point from this paper to me was thin phenotype was strongly associated with inadequate keratin mucosa. So those two problems occurs together a lot of times. So when I categorize this way, upper left side picture, number 9 is implant. You see the very thick phenotype as well as abundance of the keratin mucosa. Lower left side instead, keratin mucosa thickness is keratin mucosa width is pretty nice. However, tissue thickness is thin. And the upper right side picture, keratin mucosa is not adequate, but tissue thickness is pretty thick. Lower right side is neither. So based on that, when you look at this thin phenotype and lack of keratin mucosa width are not great condition. However, as you see that on the lower right side, neither of the presence is not great at all. So implant dentistry, we have focused on keratin mucosa all the time. So let's look at a couple papers about keratin mucosa again. This was published in 2008. They look at the keratin mucosa width more than 2 millimeter or less than 2 millimeter, two groups in the cross-sectional studies. What they found was that probing depth on the left side, gingiva index, plaque index, thickness of keratin gingiva, and the radical bone loss, those have statistically significant differences. However, no differences in the periodontal probing depth. This is really weird to me. Usually, plaque accumulation, gingiva inflammation, probing depth increases, then bone loss occurs. But periodontal probing depth area don't have any significant differences. Next paper. This came from Michigan from 2006. This paper design was similar. Cross-sectional study, then more than 2 millimeter keratin tissue, and less than 2 millimeter keratin tissue, two categories. What this group found was that only gingival index, which means inflammatory response, and plaque accumulations are two things have statistically significant differences. Otherwise, none. So this is very interesting that because I thought lack of keratin mucosa would affect health condition of dental implants for a long time. When you look at this paper from 2018, that AAP workshop paper, in the regards to hard tissue, soft tissue deficiency around dental implants, in the section of keratin tissue. On the middle area, you can see, to date, the results were inconclusive. This is very interesting. Keratin mucosa, we emphasize importance for a long time, but data itself doesn't have any conclusive outcome at this moment. Then I've been thinking why this doesn't happen first, although we as a clinician, we think that's important. Based on why this data controversial, most of studies only look at keratin mucosa. However, we clinicians need to think of the soft tissue three-dimensionally, which includes keratin mucosa on the surface characteristic and the horizontal tissue thickness as well. So not only one surface dimension is important. We need to think of a total dimension of a three-dimensional object. So when you look at this paper from Dr. Gustavo Avila Ortiz, published great paper with regards to the phenotype, peri-implant phenotype. They've defined that keratin mucosa width is top one, the mucosa thickness is horizontal tissue thickness. A3 is categorized as a supraocular tissue height, which means the soft tissue height is also important too. Then, of course, bone is important. Today, we just don't have time to go through each paper or each necessary information, all of them. But based on the accumulated evidence, we need that bone thickness 2 millimeter, horizontal tissue thickness better to have more than 2 millimeter. Vertical tissue thickness from the implant shoulder to the mouth mucosa margin should be around 3 to 4 millimeter, no more than that, or no less. Then on the right side picture, surface characteristic with keratin surface should be more than 2 millimeter. So we need to achieve these three components to maintain nice health condition for dental implants in soft tissue dimension wise. So let's look at that, how we're going to use this information or how we're going to achieve it in the clinical patient care. So how do we assess the soft tissue dimension digital treatment planning? I want to explain that digital treatment planning is very important and powerful tool to assess it. So let's look at the one patient. This is one patient that we saw a while back. On the upper right side, the congenital missing number 5 area, as well as number 12 has a congenital missing patient. Patient completed ortho, then looking for dental implant care to make a teeth that area. Then our pros partner at the time, then Dr. Life, did a great digital wax up. Then we plan for the dental implant positioning in the software. Then, as you guys do every day for the prosthetic-driven implant planning, then software was used, guide was made. Then, me and Dr. Lanlin Chow at the time, we placed implant right side, like this position, as based on the position of the guide. On the left side, this is not indicate 2.9 millimeter stroma is not indicated for the premolar area, but this is only one thing fit this area due to the limited space. So then we see the provisional crowns here. Then this is the final outcome. So actually, by looking at the permanent crowns with the final outcome, it's not bad at all. Patient was actually extremely happy because she didn't have teeth. Then looking at the 1 year post-op, pretty nice. Bone level is pretty stable, as well as the left side too. So again, patient is happy, then that makes us happy too. But when we look at this picture on the middle one, 2 pictures. So when I take a picture from the anterior view, you will see that slight concavity on those implant site number 5 and the 12 area. You see the little bit concave soft tissue dimension. Of course, we talk about a little bit we could suggest it to the soft tissue grafting at this moment, but patient went through everything, got the crown. How many patients want to go through the connective tissue graft or any soft tissue grafting at this moment? Maybe none. And also for our side, how many of the clinicians want to make an incision, even vestibular approach to the area just recently got the crowns? Maybe not. So when we came back to the digital planning, on the middle side of the picture with digital planning software picture, you can see it. So you see that the red line is actually describing the soft tissue margin or soft tissue position. The facial side of soft tissue thickness is actually pretty thin. Same on the number 12 side. Bone is sufficient for this patient. However, facial soft tissue thickness is pretty thin based on this red line on the left side of the picture. So technically, we knew that this patient's soft tissue phenotype, which means soft tissue thickness, was thin. So we maybe should have suggested to the soft tissue substitute or connective tissue graft at the time of implant placement instead of doing later. So, but how do we know that that tissue dimension, soft tissue thickness is actually accurate? So how do we measure soft tissue dimension with digital technology? So when I was in Indiana, we conducted the Kedeba study, just published in the Journal of Periodontology. What we did was that group 1, we used a K file to measure tissue thickness. Group 2 on the middle, we used DICOM data to measure soft tissue thickness. Then group 3, DICOM plus STL, we combine superimposed together, then measure the soft tissue thickness. Then beauty of this type of study is that we can actually make a slice for the histology to measure the actual soft tissue thickness. Then what we found was that the actual soft tissue thickness, DICOM plus STL, is actually higher interclass correlation coefficient to the histology compared to any other groups. So which means that daily usage of digital technology is actually really easy as well powerful tool to measure soft tissue thickness for us. So since we are using every day, please pay attention for the soft tissue component a little bit too. So after we learn this situation, we utilize to the patient. So this patient came to our clinic. Number 8 has to be extracted due to the crown fracture plus not good condition anymore for number 8. Conventional extraction with rich preservation completed. As you may see that 5 months post-op, you can see the on the facial side. So after that, we took a scan and the intro scan of both of them, then digitally planned for implant position. So when you look at this situation, you see that facial side of bone is pretty nicely okay based on implant position, implant coming from cingulum area. However, facial side of soft tissue thickness seems to be pretty thin as well. So, based on this checklist, the bone thickness is pretty okay, vertical tissue thickness pretty okay. The horizontal soft tissue thickness didn't meet the 2 millimeter due to the thin phenotype for the area. But then, according to this picture, you see that nice keratin mucosa around. So we just have to bump up the tissue thickness just a little bit for this patient. So then implant was placed with guided manner. Then we harvested the subepithelial connective tissue graft, just tack side to get the closure. So it's pretty daily procedure for everyone. Then waiting for the healing time, as you may see that the concavity was slightly compensated with soft tissue grafting. This is a final outcome for the restoration. Of course, there is a little bit of the soft tissue concavity compared to number 9 area on number 8 site. But 1 year after, it's pretty stable too, and aesthetically pretty okay outcome. So, based on this experience for us, we can use the digital technology for planning phase, not only hard tissue or implant position or guided manner, as well as soft tissue thickness dimension check as well. So that could be helpful for us to utilize or to talk to the patient to utilize soft tissue grafting at the time of implant placement to reduce surgical time and the number of surgical procedures later on. So this is a more planning phase. However, we sometimes need to check around existing dental implants, mucosa deficiency situation. So this is one of our patients again. Lower left side, you see the phenotype, non-keratin mucosa. Even you feel, actually we felt that the thread on the facial side dental implants. So what the treatment options we can provide for this patient? Option 1, maybe removing the implant due to the facial dehiscence. But it's quite challenging for us to redevelop the bone to replace the implant again. The patient actually denied the option. Then the other option is probably free gingival graft. But if dehiscence of the facial implant is larger area, FGG might not be able to survive. Therefore, Dr. Ikazaki and myself decided to minimize the risk of the future worsen the situation by using the tuberosity, a harvested tuberosity soft tissue graft. Just make a vestibular incision on the left side picture, then just slide into the area. They bump up the soft tissue thickness with tuberosity graft. On the right side picture is the outcome. So as you see that mucosal recession was treated, as well as tissue thickness gain a lot. But interestingly, keratin mucosa, on the surface characteristic, keratin mucosa didn't increase with connective tissue graft. So this is like everyone's finding, I guess, that soft tissue grafting around dental implants, we don't see a lot of keratin mucosa increases. So, but let's look at subepithelial connective tissue graft around natural teeth. So this patient, number 24, lingual side of the soft tissue grafting due to the recession plus lack of keratin tissue. Patient has a hard time to brush the area. I created a small tunneling, full thickness tunneling. They harvested slightly larger amount of connective tissue graft from 23 to 26 area. Then suture, then stabilize everything. Then this is a healing process. 2 weeks and 8 months. Of course, I didn't achieve whole root coverage on 24, but we gain a lot of keratin tissue width as well as soft tissue thickness. So this is a pre-op and post-op comparison. So soft tissue grafting, which is connective tissue grafting, actually increased the keratin tissue on 24 area. So this is the data outcome. Number 6 and number 11, subepithelial connective tissue graft plus tunneling. It's pretty straightforward procedure for everyone. This case, not only coverage, also we increase keratin tissue with CTG. So when I look at the 2015 paper, the subepithelial connective tissue graft around natural teeth. So as you see that, subepithelial connective tissue graft-based procedures provide best outcome for clinical practice for root coverage, as well as significant increase of keratin tissue. So subepithelial connective tissue graft with bilaminar technique still can cover the root as well as keratin tissue around natural teeth, which is most likely common sense for many people here today. But we want to pay attention a little bit how different behavior soft tissue between natural teeth implants today more. So this is a fantastic study was conducted with canine model. So bottom pictures are implant site, top pictures are natural teeth site. They actually excised soft tissue, including keratin mucosa plus mucosa for both natural teeth site and implant site. Then look at it. Differences in spontaneous healing between two objects. So what they found was that on the left side, if you like a histology, a little bit, this picture might be too small, but if you're interested in, please read this paper. This is a great paper to read it. But what they found was that natural teeth side, actually, they healed as keratin tissue on the facial side after excision. On the implant side, they found that that's non-keratin tissue. So after excision of keratin tissue at the implant sites, spontaneous regeneration of soft tissue is characterized by non-keratinized epithelium, which is similar to alveolar mucosa. On the other hand, tooth site, spontaneous regeneration was characterized by soft tissue resembling gingiva, which is keratinized. So this is probably due to the presence or absence of PDL as well. But this is very interesting finding. Then we don't provide this treatment anymore to the patient. This slides from Dr. Newell, who was a faculty member at Indiana, great person. I learned a lot from him. He shared the picture with me. This pushback technique, which we don't do that at all. We don't recommend doing this to the patient at all. But that's the history. So what they did was that technically they remove all the soft tissue around the area from left picture. Then they healed as a secondary intention. So under intention healing, what they found was that on the facial side, surrounding around maybe 1 to 2 millimeter area on the facial side of the area healed as a keratin tissue. So natural teeth area, even excess soft tissue, they become as a keratinized. So then Switzerland group published this paper in 2014. So if you are looking for keratin tissue around dental implants, gingival graft, or subepithelial connective tissue graft over the collagen matrix. Collagen matrix could be better regards to patient mobility and surgical time. And the bottom portion, soft tissue thickness, subepithelial connective tissue graft, and the CAF were the best documented method to gain soft tissue volume. Then the other study was conducted in the canine model again. This one compared 3 situations. Just top right side picture, A is that keratin tissue around implant and natural teeth. B, similar to the previous study, they excised soft tissue both sides. A keratin tissue was excised, everything healed as a mucosa. C, they added connective tissue grafts, subepithelial connective tissue graft under the mucosa on the implant side and natural teeth side on top of number B. So what they found was, this is very interesting again. After surgical excision of keratin tissue, spontaneous keratinized tissue is formed around natural teeth, but not around implants, which we knew that from previous paper. But important point is, regardless of the placement of CTG, which means a connective tissue graft under the mucosa around dental implant site did not enhance keratin tissue. Then we look at the Professor Zucchetti's paper a lot for the soft tissue around dental implant natural teeth. Then I read this paper long time ago, but I paid attention a little bit more for keratin mucosa portion. So we attention a lot root coverage or recession coverage for implant natural teeth, but this paper around implant site actually measured the keratin tissue increases after bilaminar technique. What they found was around 0.5 meter of keratin tissue increases after CTG plus CAF. So therefore, just going back to this paper, so subepithelial connective tissue graft might not be suitable for keratin tissue increases based on that. So let's look at the common clinical cases. So gingival graft is performed around dental implants for the locator purpose. You gain keratin tissue thickness pretty nicely. Then this patient got the reconstruction of the mandibular area. The implants were placed by oral surgery, great treatment. However, everything was mucosa around. The Dr. Ikazaki and myself did that FGG to increase keratin tissue as well as increase the vestibular depth as well. What we got the result was attached nice keratin mucosa around dental implants. So given that, if primary goal of procedure is on the left side, increase soft tissue volume, subepithelial connective tissue graft base or acerbodermal matrix, some sort of matrix could be better. And on right side, increase keratin mucosa is important. Gingival graft could be option. But negative point of FGG, aesthetically non-pleasing. Simultaneous grafting with implant placement can be challenging due to flap management. Large amount of shrinkage, and also we have to harvest the palatal site to do that. But how do we treat on the palatal donor site after FGG harvest? I used to do a lot of the collagen tape and the suture to hold it for many years, or vacuum matrix palatal stent. I have made so many times. But recently, we started using this novel technique and material. It's called Elemental. That is actually zinc fused, zinc contained polymer granules. As you can see on the right side of the video, there's granules. Then put in hot water. When you mix it around, you are getting these are becoming together. Then those are becoming sticky a little bit by themselves with heat. That's a thermoplastic. The inside contains zinc as well. So when you make a shape like this way on the right side picture, it's pretty easy to utilize it to the patient mouth the day of procedures. You don't need to take an impression. They ask patient to put the tongue back, tongue up, bite together. The biggest difference compared to those plastic vacuum matrix is that patient actually can bite all the way. So you can see the front teeth is touching. So which means that the patient can still use it during patients are eating the food. So this study was conducted, then published in the Clinical Oral Investigation group and the collagen plus suture group. What they found was that postoperative pain, burning sensation, discomfort, and dietary habit have very favor to the patient with this product. So this is one of our example for our patient. We harvested Dr. Subhani and myself. Then she did the harvested the palatal side. Nice job, and made up elemental. Then actually I like to use Stellar Life gel. Just this is very easy carrier to put in there to hold it there. Then this is post 1 week post-op. So donor side is pretty healing okay. So after using this one, I feel the patient comfort level increased it. However, still some patients really don't want to do that. That's I understand. So this is one of a patient that upper right side had extraction plus GBL previously. Lack of keratin mucosa, shallow vestibule, the implant placement of plant. Our goal of procedure is increasing keratin mucosa, so which means the FGG was in. However, patient said no palatal harvest. So we decided to use the collagen soft tissue matrix. So osteogenics has a Z-derm. It's called alternative to flexible graft materials. This can be exposed, designed for soft tissue augmentation to increase keratin tissue. This is a cross-link resolvable matrix for can substitute for flexible graft. So this is one of the example. Dr. Subhani did a great job just to make a nice thin bed, just maintain the periosteum on the surface, then added the Z-derm on the area, similar manner to the flexible graft. What we found was 10 days post-op, we're a little bit concerned about 10 days post-op that no healing is not great, but 3 weeks post-op, start epithelializing around. Then around 2 months, 4 months. So when you compare, yes, we didn't gain a lot of the keratin mucosa, but amount of keratin mucosa gain was pretty acceptable, even with substitute. So keratin mucosa width increased slightly, but mucosa thickness didn't increase a lot. So this we don't have a lot of experience yet for this material, so I can't make any conclusion, but this can be a great tool, the patient who doesn't want to go to autogenous graft. So based on that, based on that, so flexible graft, if we are on the right side, increase keratin mucosa as purpose, flexible graft, or collagen matrix could be one of the options. How, on the other hand, if your primary goal is increase soft tissue volume, subepitheal graft or acerioderma matrix could be an option. So, good thing is aesthetically pleasing outcome. We can utilize this simultaneous with implant placement or at the time second stage. We can increase soft tissue thickness, then less patient mobility with acerioderma matrix too. So we can increase keratin mucosa, but this is it's not predictable amount we can gain keratin mucosa with this method. So let's look at the patient. So this is one of our patients who we saw it, number 30, as a hopeless tooth. You see the large radiolucence on apical portion, which is actually expanding to the number 29 apex area. But 29 had a positive to the ICE test. So patients said, and we decided to try to save the tooth. We only extract number 30, clean up all the defects from the inside. But as you may see that number 29 facial side has a communication to the area. So we clean up as much we can. Then utilization FDBA and PDJ-BB. Then place graft all the way into defect area in the socket. I like to use amnion coating membrane around natural teeth area. Then non-cross-link collagen membrane to cover the socket area. The right side picture is immediate post-op. So then this one, we took a CBCT in the 3 months post-op. You see that nice bone growth, as well as nice reduced density on the area. Then similar to the previous, surface scanner plus DICOM data is combined together. Then on the middle picture, you see that, or left side picture right now, facial side of soft tissue thickness is pretty thin. Surface keratinization is pretty sufficient from this clinical feature. So we decided to do implant placement. As usual, then make sure that depth is okay to secure the supraclavicular tissue height. Then we place, it's called microderm acerbodermal matrix on the facial side of number 30. Then we cover it. So we waited for a few months. Actually, pretty nice thickness, we gain it. So this left side is pre and the right side post-op. So just a little bit of acerbodermal matrix insertion actually increase a lot of soft tissue thickness on this area. Then 3 months follow-up after the prosthesis delivery. So the good thing is that we have more digital technology. So we got surface scanner model before and after. Then I superimpose together with Geomagic software. Then just cut its position. As you see on the middle picture, you can see the dot line outside is post-op, inside is pre-op. As you may see the crestal area on the facial side, we actually gain around 1 to 2 millimeter tissue thickness. So this is pretty nice tissue thickness we gain around dental implants. Then this is 1 year follow-up. So soft tissue condition pretty nice. There's no bone loss at this moment. Patients are happy, then we are happy too. The other time 1 year post-op, just make sure to check that everything's okay, then keep as a record and get the scanner. Then we superimpose together again. So it's pretty much identical. So which means that soft tissue volume on number 30 site did not decrease it within the year from the 3 months post-op. So soft tissue grafting can be stable with EDM, acerbodermal matrix, microderm for a year. So, of course, we always discuss connective tissue graft and the acerbodermal matrix, which is better. This paper was published recently, 2021. They compared peri-implant soft tissue modification and its impact on the outcome. So connective tissue graft, CTG, and ADM. You see the black portion compares ADM plus CTG, CTG plus ADM. Upper right side is mucosa thickness. Lower left side is the keratin mucosa width. What this paper found was that there's not a lot of significant differences regards to the keratin mucosa thickness, keratin mucosa width, as well as mucosa thickness with ADM and CTG. So what is this materials? What is microderm? These are acerbodermal matrix with micro cuts. So micro cuts can help to increase the surface area, which can increase cellular infiltration and also hydrophilicity. So this helps us. We don't need to hydrate a lot, long time. So less than 60 seconds. The companies say the 60 seconds. If you hydrate too long, actually microcut component is gonna be separated by themselves. So which is not good. So we better to hydrate a little bit shorter time. So this is another case that we utilize these materials in the patient. This patient got the implant already done, but as you may see on the left side of the picture and the middle picture, we do not have a lot of keratin mucosa nor tissue thickness. But we still have enough amount of keratin mucosa, so that's why incision line was made on the middle to slightly lingual side to mobilize on the keratin mucosa to the facial side a little bit. Then Dr. Yan did a fantastic job just to raise a nice flap. And also there's two implants placed nicely the spots and no bone loss at this moment. So then we utilize microderm, tack into the facial side, as you see on the left side picture. This microcut helps to absorb a lot of blood immediately. So this is one of the possible benefits for this product. Just add the inside, then pick up the flap and the microderm together to stabilize everything together. This is a healing process. 1 week post-op, actually it swells a lot, of course, as a surgical procedure too. But 1 month post-op, 2 months post-op, 8 weeks after, soft tissue condition is getting stabilized. Then we look at surface scanner model. This is a post-op of the second stage and the microderm utilization on the facial side. Left side pre-op, right side post-op. So again, I compare the tissue thickness on number 19 site and 18 site. As you may see that two different lines on the facial side, because you can see the top portion on the healing abutment house. That's why there is a totally different shape on top portion, crestal portion. The facial portion also increased 1 to almost 2 millimeter tissue thickness by adding this acerbodermal matrix on the facial side. No palatal size harvest is necessary. Then approximately around 1 to 1.2 millimeter mucosa thickness gain around the area. So then after I look at these final processes and the clinical photos. Yeah, amount of keratin mucosa we mobilized from the crestal to the facial is still present. Then also tissue thickness from the crestal view has significant differences on the left side picture and the right side picture. So this could be a powerful tool. Again, just if you need a little bit amount of soft tissue thickness, you don't have to talk a lot about the complication or any autogenous component. Patient could be happy to reduce mobility for them. So just going back to the story again. Left side keratin with abundance, then very thick phenotype. Then second one from left side, non-keratinized and the thick phenotype. Then second from right side, keratinized but thin tissue, and the right side, non-keratinized and thin. So obviously, we would like to have both more than 2 millimeter keratin mucosa as well as thick tissue phenotype. That's the best idea, yes. And non-keratin mucosa, thin phenotypes are no good at all, which we knew that. But based on the condition in the future, especially aesthetic area, we might need to select one of them, which means a thin but a lot of keratin mucosa. Or like upper right side picture, very thick but surface is not keratinized well. Because primary goal procedure, remember, increase soft tissue volume, we can utilize sub-epithelial connective tissue graft, obviously, or like acerbodermal matrix like microderms. On the right side, if you need to increase keratin mucosa, of course, Frigiva graft will be the best. Patient doesn't want to go through the palatal harvest, or any patient taking a lot of blood thinner medication. You don't want to take a risk a lot. That sense, collagen matrix could be one of the options. The reason why I put the question mark is It's not fully evidence yet for this material, so that I put this question mark at this moment. But based on my experience at this moment, it's pretty useful too as well. So therefore, summary and conclusion for the day. So soft tissue dimension around the implants need to be analyzed carefully during treatment planning phase. If so, we can set up good situation. Then also, we as a clinician, we need to maximize benefit of data technology for soft tissue analysis, not only hard tissue, and treatment planning to reduce patient surprise later. Then, most importantly, treatment modalities for peri-implant mucosa phenotype conversion procedures are totally different from those for natural teeth. So please think about that, knowing those evidence, how to use the patient. Then setting up the best mucosa environment is an essential factor for long-term success to make a patient happier and improve their quality of life too. So given that, I would like to thank to first of all to all of you here to having me. Also, I want to give a big thank to my residents, current resident, the graduate residents, work together to think about together and improve our patient care. Thank you so much for your attention.
Thank you, Dr. Hamada. Great presentation with a lot of very insightful information. So thank you very much for that. We do have a few questions that have rolled in.
Please.
I was interested in this one too, but what percentage of patients getting implants do you estimate are deficient in one of those biologic principles? So what percentage of patients getting implants need some type of soft tissue treatment? Estimated.
That's a really good question. I can't say number well, but best everyone feels similar way. Probably at least 50 to 70% people have probably we might need to recommend some sort of soft tissue augmentation, especially thin phenotype after the extraction. That part, maybe we could do some study in the future too, that after extraction, how likely the soft tissue dimension changes as well.
Seems like it's getting, it's always been a topic, but it seems like it's a more popular topic, and I guess there's more attention being paid to it now than ever. So very interesting.
Right.
So when you're trying to measure or evaluate the soft tissue thicknesses, are you using like a intraoral scanner, or what type of technology do you use to measure the soft tissue thicknesses?
Right. So maybe the best scenario could be ultrasound. That's these days a lot of papers you see the ultrasound usage for soft tissue analysis. That would be the best scenario, just dynamic plus the moment you can check it. But it could be challenging for us to buy every single office to use it for the ultrasound wise at this moment. Maybe future that could be the. But at this moment, what I like to use is the soft tissue dimension check with intraoral scanner and the DICOM, as I show you the case a little bit. Then when you superimpose it, not only for bone position, also you can see the soft tissue line together. So that'll be really helpful plus easy solution, because you're gonna use the majority many times you might make a guide, or at least you have DICOM plus STL. When you put together, it's actually you can see pretty nice outcome too.
Okay. I think this question came in early in the presentation, but I do think it's worth you adding some commentary to it after we've seen the presentation. The question is basically, your feelings about allografts versus, I think we have the ADMs, we have the collagen matrices. I think you explained when, the purpose of those materials, but how do you determine if you're going to use an autogenous graft or one of those alternatives? What are the decision criteria, decision tree that you go through case by case to determine what you're going to use?
I think. So can I just go back a little bit? Yeah, is that okay? Just show the screen or. So yes, so Uh, Still, I believe that autogenous could be the gold standard for this type of procedure anyway. That's pretty sure, since we do not have a lot of long-term process for the SR matrix or collagen matrix for FGG purpose, especially FGG purpose. If you need a lot of keratin mucosa, Frigival graft could be better solution at this moment. But the area amount of the surface is a lot. For example, after the big FGG, that situation, collagen matrix can be utilized. Like Professor Esteban Arban described that using the strip graft, which is developed by Dr. Takei from UCLA. Then the other area, utilization of collagen matrix, the combination could be a good solution too. But if we want to increase keratin mucosa, FGG could be the better solution at this moment, as far as I know. But combination for strip graft and the collagen matrix could be useful too. Then also, of course, depend on the patient situation. Shallow palatal vault, then a lot of medication patient taking, blood thinner medication. I don't want to harvest a huge FGG for the area. That sense, maybe small amount of strip graft or the collagen matrix can be utilized. Those are case by case. They also increase soft tissue volume. Yes, I agree. Soft tissue sub-epithelial connective graft should be still gold standard. But based on my feeling these days, using the microderm more for this purpose, I start getting convinced a little bit that amount of soft tissue thickness we need a little bit. It's way faster the treatment procedure, as well as patient mobility is lower. So that sense, utilization of SR matrix, if you need a little bit amount of tissue thickness bump, could be helpful. But the case I show you that implant surface is already exposed, very thin phenotype, that situation, I'm not confident to utilize the SR exposed a lot, they might not take well. That sense, CTG could be better, but I haven't tried the microderm for the peppers, so I can't make a comment for the portion at this moment.
Understood. So speaking of the Cytoplast microderm, when you're placing it, like in this case we're looking at here on the left, are you placing it under the periosteum, or are you using a split thickness flap?
Yes. So this one, actually, this is a good example to show. To answer your question, I like to place because at the time implant placement, we elevate, or second stage, we elevate the full thickness flap. Therefore, I like to place this inside the full thickness flap. I don't want to make a partial from here anymore. That's safer, and there's no I don't think a huge difference is at this moment.
This might be a good case to answer this question too. We have a question: how do you stabilize the microderm underneath the flap?
Yes. So that's a really good question. Then I discuss with residents all the time. The microderm or any graft material might come up. So make sure that the microderm is actually not touching to this healing abutment. So if flap, so let's say place microderm or CTG slightly apical to the flap edge has to touch the healing abutment. So that then when you determine the hard vertical position, you can pick up. I like to use 5-0 glycolon for this situation for 100% time. The pick up, flap, and the substitute graft substitute together with different level. So microderm has to be more apical, or CTG has to be more apical. They pick up together. Then lingual side just single interrupted. Then these are just 1, 2, 3, 4, 5 single interrupted. That's it. But you need to pick up both together, but position has to be different. Means that the vertical discrepancy need to be required to stabilize the soft tissue nicely.
Yeah, we get that question a lot.
If we can do hands-on in the future, that's great. But I should have taken a video. I could have taken a video, or I might draw the line in the next presentation, I think. That's a good question. Thank you.
This is a good question to test your knowledge of the research here. What does the research say about preferred timing of soft tissue grafts? Pre-implant placement, during healing, after implant placement, after the final restoration? What does the research say? What's recommended?
Yes. So the actually ITI, the soft tissue ITI treatment guide has a soft tissue grafting component. I feel like I'm taking the exam right now, but but the ITI study guide, treatment guide has that a lot of the what's called the timing of soft tissue grafting. One is before, one is simultaneous, one is after. But everyone, I think, believe that after treatment is more likely the fixing the problems. So soft tissue deficiency happen, we are fixing the problem. If final restoration is in, as you can guess, it's extremely challenging to manipulate the flap nicely. So at least better to do before implant placement or at the time implant placement. Then my personal, then yes. So then when you do the FGG at before treatment, before implant placement, you might get the scar tissue a lot. So if the site requires a lot of the hard tissue augmentation, it's hard to expand to get the primary closure. So that sense, my personal philosophy plus based on those knowledge, hard tissue graft first, implant placed, soft tissue at the end, before final restoration. That would be most predictable way to achieve nice outcome. But then if you ask me what research shows the differences, I'm not fully aware that the specific question to answer. But those are more practical standpoint. I kept asking many people same questions for the people verify, but I get the different question answers sometimes.
Understood. Well, good. Got time for a couple more, and then we'll wrap it up.
Sure.
You've had experiences with the microcut ADM, the microderm. Have you experienced any differences with that product versus traditional smooth surface allograft ADMs?
Yes. So when I hydrate it like a little longer time, the one of my resident myself the treating patient, then we put the microderm into the saline a little longer time. Then when I place into the saruka, actually it's a vestibular approach. When we use a vestibular approach, they tear, then they are gone inside the flap by themselves. So which means that consistency wise, without the microcut could be stronger if you have to manipulate under the flap a lot. Or just don't hydrate too long. But it could be interesting study. Maybe someone can what's the difference heating process plus thickness changes before and after. I don't think none of the studies available to compare direct study. But without longer hydration time, the microcut ADM is actually easy to manipulate it. They're strong enough. Then conventional ADM is sometimes too flimsy, and that sense it's hard to stabilize in the flap nicely. They come up sometimes. Once it's exposed, so they might get infected all the way. The microcut one, just one part is exposed. The microcut component can just eliminate the exposed one. So that's my feeling at this moment for experience so far.
I think we'll wrap it up on this one. A little bit of clarification on some of the measurements you showed. When you say the horizontal mucosal thickness is important, are you talking about horizontal thickness at the supracrestal area? And is it including the attached mucosa area?
The paper described that more for supracrestal portion of the soft tissue thickness. This part is not fully proved, But if you increase more apical portion soft tissue thickness, sometimes corner portion tissue thickness gain together. But that's like kind of my personal experience, which I show that too, because the microderm position is actually more apical, but the corner portion soft tissue thickness getting thicker too. Yes, so better to have 2 millimeter tissue thickness supracrestal component to hide the color of any restorative materials. But as regards to the health condition wise, the soft tissue thickness is not fully established evidence that how many millimeters do we need it for the future health. That is probably future study will be needed to prove the concept.
So, well, we have more questions rolling in, but we are out of time, unfortunately. So, out of respect for everybody's time, we'll go ahead and wrap it up there. Dr. Hamada, once again, thank you so much. Appreciate you, appreciate your time and your knowledge. It's a pleasure to work with you. We really enjoy it here at Osteogenics, and this was exactly what we expected to be. It was fantastic. So, thank you very much.
No, thank you everyone so much for being here and great questions. And if I could answer well, you can contact us again anytime. Thank you.
All right. And just for the audience, real quick, make sure that you're on the lookout for the survey that will be emailed out to you as soon as we log off here. Please fill out that survey. We always appreciate the feedback, and it also is what triggers us to send your CE certificate back to you. So once again, thanks, Dr. Hamada, and thanks to everybody that logged in, and have a fantastic Thursday evening. Bye.
Thank you so much.